So you'd like me to introduce myself?
Yeah, sure.
Okay. Well, my paid work is as a professor in the Department of Community Health and Epidemiology at the University of Saskatchewan. And I teach in this area called global health. And how I got there is a long story, but it is part of my introduction, actually, and part of how I see the field. And that includes a long time of working particularly in Central America, in Nicaragua, but in lots of other places of the world in the field of community health, community development, and then informally as a solidarity activist, which sort of defines, as much as the professor role, my work.
Right, and well, we could start talking about the IMEs, what they are and what you think about that.
Can I back up to an earlier story? Okay. The field of global health, I think, is sort of where the background to understanding what IMEs are is probably important to sort of talk about a bit. And there's lots of different sort of historical accounts of how we come to have this field, academic field, called global health. And some people would say global health is not even an academic field, it's a set of problems to be solved. But the academic field of global health sort of arose and was defined by people who had worked primarily in areas like international health, or in public health, or in tropical medicine. And so the official definition of global health has been evolving over time and includes sort of an outgrowth of those three things. And an outgrowth and an extension. So as originally conceived, global health seemed like a really exciting field in terms of being concerned with responding to social determinants of health, being multidisciplinary, the approach being multidisciplinary, the approach to necessitating actions that were cooperative or in collaboration rather than being kind of north-south directed, which was more akin to the field of international health. And those kinds of things were kind of very appealing to a person who had the kind of background that I had. So when I came into the field of global health, I was quite enthused by seeing a new definition of the kind of work that seemed to represent the field, that seemed to represent the kinds of things that many health and social activists had done in the field of health, and community health in particular, over the years. So that sort of field then became very quickly, like wildfire, it really spread, this idea of global health and this academic field of global health. So we saw just an expansion. It's like it's like this huge expansion of centers and institutes and programs and courses and all kinds, particularly of medical schools, but also in fields of nursing or allied health sciences, even a little bit in development studies and other fields of this field of global health. So it's been growing exponentially. And I'm speaking particularly of the North American experience. I know it's been similar in Europe, but I don't know the European experience quite as well. So when people are thinking about this new field and what it might entail and so forth, you have this really huge growth of interest on the part of students. And now I'll speak primarily of medical students, although all kinds of students are engaged in it. Medical students are becoming very interested in this field, and there's these opportunities are starting to get created, but they're not kind of getting created as fast as what medical student interest is. So medical students want to do global health. They want to work in global health. They want to learn global health as they understand the field. And what happens that you see a really rapid increase in the numbers of students who are looking for ways to learn global health, and the institutions and the faculties and the professors and the courses and so forth on the academic side aren't quite keeping pace. So you have the growth of this thing called the International Medical Experience or International Medical Elective, or they're all kind of grossly lumped in that term because they have some similarities. And the International Medical Elective then becomes sort of, is kind of described by its characteristics. It's some kind of immersion in countries of the global south by typically an undergraduate medical student. That's the ones we're talking about here, the undergraduate medical student who goes away during a summer term for, say, anywhere from 4 to 8 weeks to spend some time in volunteering in a clinical setting in a country of the south. And those international medical electives quickly became the most typical, or the most, they became normalized as the way that medical students were learning global health. Even though this field over here states that it's about a whole bunch of other things, the way that students were learning it was through international medical electives. So you see the growth of these things by looking at the actual rates of participation in them. Some 15 years ago, as documented by like the exit surveys by American students, for example, there were 8% of medical students that were partaking in some kind of immersion experience or elective in the global south. By 2007, we have 1/4 to 1/3 of all undergraduate medical students who are now participating in these things. And they're participating without a concomitant or a commensurate sort of set of activities that are academic activities to prepare them for this. So academics are struggling to sort of try to keep up with where their students are going. And in the meantime, you have all kinds of different experiences that are starting to be kind of lumped under this category of international medical electives. So you have, let me describe 3 kinds. There's sort of the NGO experience where any medical student, or any person for that matter, it doesn't even have to be a student of medicine, can simply go online and try to find volunteering opportunity in a country of the global south. And that volunteering opportunity might be paid for by an NGO, or rather you pay an NGO to organize it for you. So the NGO might offer you the opportunity to volunteer in a number of different settings. And it may look like you simply arriving, being met by somebody and being taken to a clinic where you participate in daily activities that are going on there. The other kind might be an international medical experience where there's some kind of academic involvement, perhaps some kind of personal orientation that's offered, travel risk and safety kinds of one-day seminars, and your professor that perhaps, and I don't mean to say it cynically, but met somebody once at a conference and that happened to be from a country of the global south, and you just put that student in contact with them, and the student goes off to meet them and to, again, just volunteer or do something in that clinical setting where that person's working. That's another kind. And the third kind is becoming more and more organized over time as sort of academia responds to it. And that's the kind that are becoming actual offerings or programs or courses or even certificates in global health that involve a long-term partnership that some academic institution might have with either another academic institution or a clinic or something in the global south that receives students and that also has faculty that accompany those students to supervise them in an elective. The third kind is, of the 3, probably the least problematic from lots of points of view. But all kinds exist still. So some are very one-off and volunteer-based.
So you said the word problematic. Mm-hmm. What's your opinion on these IMEs? And what do you think is the result they have on the students that actually apply and go for these IMEs? And again, and this is a personal question, what might be the difference between one experience of this kind, of an international medical elective, and your experience that was made as well in the global south in Nicaragua? And this is a question just for trying to understand how could it, what does it make the difference, okay, and what leads to a result or another one instead of the other one?
Well, first off, there's not very good evidence here about what works and what doesn't work. most of what exists in the literature, and this is based on a literature review that was done a few years back, most of the literature around these international undergraduate medical electives is based on self-reporting, case study. It's not really rigorous research overall. And by and large, what is reported, because it's self-reports, are that the students are, in terms of benefits, are receiving all kinds of benefits, and so are health systems of the North, because students who go on these, by and large, are tend to be motivated, not all, but tend to be motivated by quite altruistic kinds of goals. And they go and they offer some kind of, they have some kind of experience. When they come back, they seem to be more aware of, and according to self-reports, again, this is not hard, really great research, but according to self-reports, they're more interested in things like family practice, things like public health. They understand better social determinants of health and have better appreciation for the influence of social determinants. They're more likely to want to work in marginalized communities when they get home. So there's a lot of positive benefits for home institutions, for the students themselves personally. And there's also a lot of benefits for northern systems that are struggling to find people who want to work in those kinds of fields. So in terms of benefits, that's what's being reported primarily in the literature. There's a dearth. There's at this point, from literature reviews and ongoing searches that I've done, there's virtually no research that documents the experience of the Global South in receiving these students. So the cost of these things, and here's where some of the problems come in. For particularly those experiences that are ad hoc, short, unaccompanied, and so forth, someone in the South is looking after the organization of these students, the ongoing supervision of these students, their everything from their daily needs to looking after them while they're in the hospital or in the clinic. So, at the expense of what is what we have to ask? At the expense of whom? There are all practitioners in lots of practitioners, the majority of the practitioners in the Global South are overburdened. They have their own students that they need to teach. They have their own patients that they need to see. And if you can think about a North American student who perhaps doesn't speak the language, doesn't understand the culture, has very little background in sort of issues around even tropical medicine or global health or any related disciplines, just going to volunteer, they may not be doing much of a service at all. And in fact, they can be a great cost to the health system of the country of the Global South. This is mentioned, it's increasingly noted, the problems are increasingly noted in the literature, even in these self-reports. There's also a bunch of ethical issues that relate to what happens when you take a student who's ill-prepared and who's come from a country where the media reports of what we see in Africa is all that they've got to go on in terms of their understanding of how things work in the country of the Global South. So there's a lot of built-in colonial attitudes and a lot of they're working from a position of privilege, they're working from things that they haven't self-questioned before, and they arrive in a country where they see and they judge things to be not working very well. And so you have those students who are ill-prepared arriving and sometimes being put into situations that either because they put themselves in those situations or because they are put into situations that they're ill-prepared for. They're practicing things that are outside of their competency zone. So there are actual reports in the literature, for example, of third-year medical students doing hip replacements, of second-year medical students doing cesareans, of people who are put into even primary care situations where they're providing patient advice on conditions after 1 or 2 years of undergraduate medical training. So they're practicing outside of the competency zone. For when sort of you see the colonial sort of hand being raised, or where you can sort of see it, is again, there's also reports in the literature of situations where students, because they're perhaps in a situation where they feel that they should, they can, there's a bit of a double standard. There's things that they would never do at home that all of a sudden they feel that they're privileged to be able to do somewhere else. So the situation of being ill-prepared and the situation of being unaccompanied and, you know, one-off kind of situation leaves them, you know, in a very precarious situation, both in terms of what they're learning and also in terms of how they might be practicing. There's lots of ethical questions that, and you can do, you know, you can think through. The literature is actually full of examples of situations where there are really huge ethical questions about whether this is the right way to go about it. From a larger perspective, like in terms of pedagogy, sticking a student into an unknown situation on their own anywhere without mentoring, without preparation, without follow-up, without reflection is really bad pedagogy. It's terrible teaching. It's non-teaching. It's not a learning situation. Right? So the lack of any kind of understanding pre and post of what this student has gone through can end up then with the student reinforcing all kinds of colonial attitudes that they went with, rather than learning anything that might in fact move us in a world closer to a world where there's some solidarity rather than some colonial kind of reinvention that's going on. So I think that the IMEs as a practice is really problematic, particularly some kinds, but perhaps even, and I venture to say with undergraduate students, perhaps all kinds that are particularly clinically based.
And again, well, you say you're working in the field of global health, and what you actually do in your university for a better teaching for.
Well, I don't proclaim to be God, but there are some things that what I've seen, what I've learned, what I understand, that make me very much shy away from early experiences when students are learning about what could be the issues in this field around solidarity in particular, and how to work towards global health equity. I think there are other kinds of skills, beyond clinical skills, beyond technical skills, that students need to get. They need to have different ways of viewing the world. They need to be challenged and be self-reflective about their place in the world. They need to learn all of those kinds of things through experiences that challenge them and that don't put them on a pedestal, like arriving in somewhere in a country of the global south with your white coat on when you're not even a practicing physician. So I think I stay away, in what I do, I stay away from the kinds of experiences that will reinforce privilege. That's sort of a practical principle. And what I try to do to a lesser or a greater degree with all of my teaching is to make sure that students are both exposed to and challenged by people that are working in communities anywhere in the world to better their own lot, i.e. where it's not profession-led. So my work in global health takes students and places them together with campesinos, for example, in working in cooperatives in rural towns of Nicaragua who are trying to better their own lot. They have their own responses. They have their own ways of dealing with the living conditions that they live in. So if you want to learn social determinants of health, don't even go to the clinic. You don't need to, really. You might want to look at it, you might want to observe and see what the health system has to offer somewhere. But that's not the place of learning when you're first learning about these things. You need to open your eyes to how other people think, to how other people respond to their own problems. You need to understand that in order to be able to work with it rather than trying to impose some kind of other way of thinking about problems that comes from the north. So people work alongside and are led, and the programs are led by the organizations that I work with in the South. And they're, by and large, civil society organizations. My teaching in global health involves work in learning about fair trade. Because fair trade, for example, has been one of the responses that people are trying to organize to see if the market can offer some kind of social justice. It's one of the ways, just for example. It involves understanding cooperatives as a method of community organization that helps people survive. It involves walking alongside people who are working in social movements, such as the women's movement. So it's a different approach that's that's much less clinically based and more community based, because I feel like what I'm seeing, what I'm sensing, and again, this is not research based, because it hasn't been done yet, it's just based on what's in the literature, that what we're teaching students is not going to, in fact, do much to create global health equity. If anything, it'll make it worse. So I think if you really want to teach it, we have to challenge the kind of the dominant mode of thinking about what our work in teaching involves and what we expose our students to and who we want them to be at the end of the day, which is, I think, people that work in solidarity with people that are struggling to make their life better, not coming with preconceived solutions or technical solutions to long-term historic and political problems.
I think that we're done. That's it, that's all.
Okay.
Thanks a lot.
Okay.